ENIGMA stands for Establishing National Guidance for Idiopathic Granulomatous Mastitis. This study, published in the Journal of Clinical Pathology in 2025, is the first comprehensive scoping review of diagnostic practices for IgM. The review analyzed 225 studies involving over 13,000 participants, published between 2003 and 2023. IgM is a rare, benign, chronic inflammatory breast condition, first described in 1972. It is a diagnosis of exclusion, meaning other causes must be ruled out before this label can be applied. The key problem? There are currently no established diagnostic guidelines for IgM. Let me provide some background. Idiopathic granulomatous mastitis, or IgM, is a rare benign chronic inflammatory breast condition first described in 1972 by Kessler and Wallach. Patients typically present with a tender, palpable breast mass, sometimes accompanied by ulceration, abscess formation, or fistulas. Microscopically, it is characterized by lobulocentric inflammation with granulomas that are typically non-caseating. Crucially, IgM has no specific clinical, radiological, or histopathological features. It is a diagnosis of exclusion. This scoping review aimed to evaluate histopathological and microbiological approaches used to diagnose IgM, with particular attention to excluding tuberculosis and cystic neutrophilic granulomatous mastitis, or CNGM. The authors searched three major databases covering publications from 2003 to 2023, ultimately including 225 studies with over 13,000 participants. Histological assessment was performed in 72.5% of participants across 184 studies. Core biopsy was the most common specimen type, used in 116 studies, covering over 5,700 participants, followed by excisional biopsy and fine needle aspiration cytology. The review found that granulomatous inflammation was reported in 97 studies. The presence or absence of caseation was reported in 66 studies. Critically, caseation was present in about 1.2% of cases where it was assessed, which raises concern about missed tuberculosis infections. Importantly, 104 studies did not even report whether microorganisms were seen on histology. The data support using core biopsy or excision biopsy over FNAC, as cytological findings in IgM are nonspecific. No studies suggested excision is superior to core biopsy for tissue diagnosis. This slide reveals the most concerning finding of the review: the widespread failure to adequately exclude infectious causes, particularly tuberculosis. A staggering 75% of studies had no means to rule out TB beyond Zeal-Nielsen staining. ZN was the only TB test used in over a quarter of studies, despite its sensitivity in formalin-fixed tissue being reported at just 2 to 39%. Only 14 studies, covering just 5% of participants, performed mycobacterial culture, which is the gold standard for TB diagnosis. Only 47% of studies even reported using basic microscopy and culture. Perhaps most striking, when advanced molecular techniques were applied, Corynebacterium croppenstedtii was found in 39 to 70% of cases, suggesting that many cases labeled as IgM may actually be cystic neutrophilic granulomatous mastitis. This is clinically significant because CNGM requires antimicrobial treatment, not immunosuppression. This slide illustrates the core diagnostic challenge. Three conditions can present with overlapping histological features. True IgM shows non-caseating lobulocentric granulomas with negative cultures and requires exclusion of all other causes. TB mastitis shows caseating granulomas in about 41% of cases, but can also present without caseation, making it indistinguishable from IgM on histology alone. CNGM shows lipogranulomas with central vacuoles surrounded by neutrophils and is associated with Corynebacterium croppenstedii. Critically, CNGM can evolve histologically to resemble nonspecific granulomatous mastitis over time. The treatment implications are profound. IgM may be treated with immunosuppression. TB requires antitubercular therapy, and CNGM needs targeted antibiotics. Giving immunosuppressive therapy to a patient with undiagnosed TB or CNGM could be dangerous. This is why histology alone is insufficient. Microbiological correlation is essential. To conclude, this scoping review has exposed substantial heterogeneity and gaps in the diagnostic workup for IgM. The key takeaways are: first, we need a standardized, comprehensive diagnostic framework, one that brings together clinical, histopathological, microbiological, and epidemiological factors, rather than relying on histology in isolation. Second, microbiological investigations, particularly mycobacterial culture and targeted Corynebacterium identification, should be mandatory rather than optional. This is especially important when immunosuppressive therapy is being considered. Third, the reliance on Zeal-Nielsen staining as the sole method to exclude TB is wholly inadequate given its sensitivity of just 2 to 39%. Finally, the authors propose that these findings, alongside current practice questionnaires, will feed into a Delphi study to develop multidisciplinary clinical guidelines for IgM diagnosis and management in the UK. The Enigma group proposes distinguishing between true IgM and secondary granulomatous mastitis to ensure that the idiopathic label is only applied after rigorous exclusion of known causes. Thank you.